I've been working with HIV patients since the beginning. And I was in the Air Force when all military HIV patients got sent to Wilford Hall Medical Center, which is where I was doing a residency. And that was in the scariest of times where we just didn't know. And I have a lot of HIV patients who I tell them about the things we're going to talk about tonight. They kind of have this look on their face, and I say, what's wrong? And they're like, well, I never thought I'd live this long. I truly never thought I'd live this long. And yet here you are, living this long. Because really, in my opinion, miraculous interventions, changes, and discoveries that have changed everything. And for the most part, a chronic disease, from a lethal disease to a chronic disease, is pretty exciting. So the things we're going to talk about tonight, you got to worry about them, right? You got to worry about them. So let's jump in and get started. So first of all, 50% of men living with HIV today in the United States are over 50. So that's this group, right? So that's 50%, so that's a lot. And life expectancy approaches HIV negative peers now. You're aware of that, but it's miraculous. I don't think we can state that enough of where this has all come from, where we've come from, the treatments, the options, and everything else. So we do have to pay attention to how we age gracefully and avoid some of the problems of age. All of these have references as well, if you're interested. And I'm happy to answer. If you have questions as we're going through, just raise your hand. It's very informal. So just stop it. Okay, so we're going to talk a little about epidemiology of the aging HIV-positive men. We're going to talk about LUTS. Does anybody know what that even means? LUTS stands for lower urinary tract symptoms. So all the things that bother men, we lump into LUTS, L-U-T-S, lower urinary tract symptoms. Getting up at night to urinate, LUTS. Frequent daytime, LUTS. Urgency with occasional incontinence, it's LUTS. It's all LUTS. That's what that's about. Prostate cancer, we're just going to mention, we dedicated an entire seminar to that at our last time. Still interesting. We'll talk about that. Renal disease. We're going to review HIV-related malignancies. This is really important. And we're going to talk about that. And then some evidence-based screening strategies we're going to review. So the age distribution of men living with HIV, as mentioned, 1995, not so high, and today, much, much higher. So let's talk about prostate cancer and HIV-positive men. We're only going to touch on it because we did it for an hour last time. And so if you didn't come, we didn't have free food in this problem. Did we have free food? Oh, we did have free food. So that wasn't it. Those are the criticisms. Okay, so overall incidence is interesting because of all the things HIV men suffer from, you actually have a slightly lower chance of getting prostate cancer than HIV negative men. So the very few things that are real positive about it, that's one. But you still have to pay attention to this, which means you need a PSA. The problem with HIV and prostate cancer is they tend to present at a later stage. And we're going to show just a little bit. Your PSA can be deceptively low. And so the thing that we fear the most as urologists is low PSA producing prostate cancer. And I saw a patient like that today. His PSA is 3.8, which is actually perfect for a 70-year-old. And this guy's got positive aggressive prostate cancer in every single core that we biopsy. So you can be led astray by your PSA test. So we're getting away from rectal examinations because the rectal examination, a good rectal examination, I can feel 10% of the prostate, right? So that's not very much. And we used to think that most prostate cancers would arise from the rectum side of the prostate. So it made sense to check that part. But it turns out that now we know so much about prostate cancer, many prostate cancers arise from other parts of the prostate. You can't get anywhere near to feeling. So we do MRIs. We have a low threshold for MRI because with the MRI, I can look under the hood and I can see 100% of your prostate. I can see inside, outside the edges, I can see everything. And we have very strict radiographic criteria that tell us whether that prostate is abnormal and whether it needs to have a biopsy or not. So the exception to that is the HIV-positive patient who comes in and their PSA is somewhat low, but they're having lower urinary tract symptoms. That patient needs a rectal examination. Because on rectal examination, even if you can only feel 10%, you can feel that that prostate is distinctly abnormal. So prostate cancer has a rock hard feeling to it. And if you feel a prostate and it's rock hard, it doesn't matter what your PSA is, you need an MRI and you're very likely going to get a biopsy. So that's what this is all about. So PSA may underestimate the disease. So, but you still want to make sure you get a PSA every year. Earlier we were talking about our primary care doctors are getting away from PSA. Long story. Many years ago, the U.S. Preventive Task Health Service, the U.S. Health Preventive Task Force said you should never get a PSA. It wasn't helpful. It led to way over treatment of prostate cancer, and you would never die of prostate cancer. You might die with it, but so don't get a PSA. So our primary care doctors stopped. But prostate cancer is the #2 cause of cancer deaths in men behind lung cancer. And it's remained that way for the last 30 years. So it doesn't make sense not to screen a cancer that can be lethal in men and is the #2 cause. So you got to get a PSA, all right? That's the bottom line. Got to get a PSA and plus minus a rectal examination or plus minus an MRI, but prostate cancer is a big deal. Lower incidence, HIV positive, but more aggressive HIV positive, so you got to get screened. All right, any questions about that? I saw you were nodding when I said primary care doctors are getting away from it. Has anybody else had that experience? Yeah.
I had to ask for one.
You had to ask for it, yes.
I recently asked my physician for it, and he told me exactly what you said about leading it to all sorts of unnecessary things. I went ahead and had it, and it's normal, which lets me ask, what indicates the need for the MRI you've discussed, and also, is endoscopy and the biopsy that could happen during endoscopy at any way related to cancer diagnosis?
Great. So question was, number one, what would indicate that you needed additional testing? And what about the biopsy? Is that the question?
Yes.
Okay. So if your PSA is low, but you're having symptoms, lower urinary tract symptoms, we need to check your prostate. And if your prostate is firm or hard, then you need a prostate MRI. All right, that's the answer to that question. Now, sometimes it's easy. You beg and you borrow and steal, and you finally got your PSA, right? And it was abnormal. You need a prostate MRI, period. That's what you need. And the MRI, the reason the MRI is so important, we should talk about this. If your MRI is abnormal, the radiologist will automatically do a 3-dimensional reconstruction of your prostate using this very expensive software program. But then when we do the biopsy, we can pull that 3D reconstructed prostate MRI image into the biopsy room, and while we're doing live ultrasound, we can overlay the ultrasound images on top of your MRI images and make sure that we hit the areas that the radiologist said were abnormal. Now this is amazing for me, because when I first trained in urology, we didn't even have ultrasound. You had to put your finger gently on the needle, gently guide it into the rectum, and then gently try not to biopsy your finger and put the needle in the prostate somewhere. And we've gone from that to an MRI, 3D reconstructed prostate, the lesions that have been deemed abnormal, also 3D reconstructed. We use a fusion software on a machine called a UroNav, or a smart biopsy, or a fusion biopsy, 3 names for the same thing. And when you leave the room, I can with great certainty tell you we sampled these areas that were abnormal. That's why the MRI is so important. It's not just that we got an MRI that looked abnormal. We can then use the MRI in a smart and intelligent way. Now, biopsies. You should not let somebody do a trans-rectal biopsy. So we used to biopsy everybody through the rectum. And it turns out that worldwide, 3 to 6% of men who get biopsied through the rectum get septic and end up back in the hospital. That's a really high rate. Wow. But if we do a transperineal biopsy, I'm going to tell you how you find that area, but please don't do it right now. If you lift your scrotum up and you push right underneath your scrotum, you're pushing right on your prostate. So instead of biopsying you through the rectum, we take the scrotum up, we put an ultrasound probe in the rectum, and then we put 2 tiny holes right underneath the scrotum. We go straight through the skin, and the sepsis rate with that is 0. So when they recruited me out of New York to come here and help with the prostate cancer program. And I promise you I'm not just going to go on and on all night about prostate cancer. But they recruited me out of New York. And we outlawed trans-rectal biopsies in New York. at Northwell, where I was the chairman, because the sepsis rate was so high. You just can't sterilize the rectum. And it doesn't make sense to biopsy somebody through a fecal stream. It just doesn't make sense. So we outlawed it, and we only biopsy through the perineum, underneath, through the skin. And we looked at, just before I left New York, I pulled 3,000 transperineal biopsies, and there was 0 incidence of sepsis. So don't let somebody do a trans-rectal biopsy. It's old technology. This should be done transperineal. And in New York, we did all the biopsies in the office with just a little bit of a Valium tablet, 10 milligrams, and a Vicodin tablet. And the average pain score with that was 2 out of 10. The equipment that we have at Eisenhower to do these smart biopsies is in the operating room. And in New York, it was in our clinic. And we noticed that the operating room was really close to anesthesiologists. And since they're all really close together, we just give you IV sedation. So we do it in the OR, IV sedation. It takes 8 minutes to do a biopsy. You go home the same day. The next day you can do anything you want. You get 2 tiny holes underneath your scrotum, and off you go. And then we get our answer. So it was a long answer. Did I answer your question?
That was great. Can a primary care physician refer me to you?
Yes. Yes. Okay. Any other questions? We're moving on. I said we're going to be short on prostate cancer. So we're going to move on. What questions do you have about biopsies, MRIs, PSA, or prostate cancer in general? Yes?
How often, when you say PSA, how often should you ask to have that done? Annually?
Just once a year.
Just once.
I see patients come in and they're getting a PSA every 3 months. I think they just wore their primary care doctor out and said, all right, now I'm only going to get one. We'll get one every hour. Right? So once a year is all you need. Prostate cancer, even aggressive, is so slow growing that if we got a PSA this year and you develop prostate cancer and we didn't see a bump until next year, you're going to be just fine. It doesn't grow that fast. Question?
What is baseline PSA?
Now you just opened it up, didn't you? That's the hardest question. So if you're around 50, your PSA should be about 2. The lab says it should be about 4 or less. Some labs say 3 or less. So then we have this problem of activity that changes PSA. And in preparation for the prostate talk that I gave last year, I did a literature search looking for PSA values in receptive anal intercourse to see how much that changed. And you know what? It doesn't exist. That data doesn't exist. So we know that if you get a vigorous prostate massage, your PSA can go really, really high, right? If you get prostatitis, your PSA could be 100. And so there are things that change that. Sexual activity, ejaculation will bump your PSA just a little bit. It won't make your PSA go from 3 to 6, but it might make you go from 3 to 3.5 or 3.8. But sexual activity, receptive anal intercourse, prostate massage will raise the PSA. So we really encourage you to avoid any of that for 7 days prior to getting your PSA. All right? So it's complicated. Your question is so good. I'm trying to get Eisenhower to do what we did in Salt Lake City when I was chief of urology at Intermountain Healthcare, and what I did when I was chief of urology at Northwell in New York, which was to use these pretty complex and regularly updated algorithms to say, based upon your age, based upon your rectal examination, your family history, all of those things, it will tell you what your PSA should be. So just a quick diversion, if I know that you're 65 and your PSA is 3, your chance of having prostate cancer is between 6% and 68%. So what does it depend on? It depends on what medications you're taking. It depends on your family history. It depends on your rectal examination. So we're trying to get them to incorporate these already established charts so that when your primary care doctor does get a PSA, it just lists 16 different possibilities. So your primary care doctor knows what your rectal examination was, your primary care doctor knows what your family history was, and knows which medications you're on, and then it helps stratify it. So my argument to Eisenhower is just knowing your absolute PSA is not enough. It's not enough. We need to know everything else about you, age, race, et cetera, medications, et cetera. Then I can tell you what your PSA should be. See how you open? You just wide open.
follow-up question.
Pandora's box, follow-up question, and then a question back here.
Is there a, like an online calculator, like a Framingham with a score calculator?
So there used to be, and they took it down. And my boss, who came up with he did a beautiful study, was published in 2002, New England Journal of Medicine. 18,882 men randomized to placebo or finasteride, which is common, Propecia, same drug, because he thought that Propecia or finasteride might decrease your chance of getting prostate cancer. And that landmark study published in 2002 showed us that an absolute cutoff of PSA was worthless, and you needed to know more: medications, family history, age, etc. And he put the calculators online, and they've since been taken down. And that's a problem, and that's why I want to get it implemented in Eisenhower, where every time you get a PSA, it just spits out this chart, 16 different variables, and you can say, your primary care doctor, and you can say, oh, look, oh, that's me, that's my race, that's my age, oh, you know, my risk is, what, 28%? Maybe I'm going to ask for urology referral. Yes, question in the back.
What impact does aging have on any of this?
Same thing. Same thing.
So it's not, it doesn't add to it.
It can very likely change your PSA. Yeah. Another question? You're just raising your injured hand.
It's broken.
Okay. So if you have a question, raise your other hand.
I was diagnosed at 68 with 4.2. And because I was on warfarin, they only did a very few, they were afraid, you know, some of the descriptions you said. But then I ended up being a Gleason 8. And so 2 months after the discovery, I was operated on by City of Hope. And it had already breached.
So
18 months later, I had to go under 8 weeks of radiation.
So the comment was, do you mind if I repeat it?
No.
The comment was, okay, I got diagnosed when my PSA was 4.2. And then I got my biopsy and I was Gleason's 8, and it's 8 out of 10. And every time we go from one Gleason score to another, it's an exponential jump in aggressiveness. Okay, so if your Gleason score is 6, it's just 6. If it's 7, it's 10 times more aggressive than 6. If it's 8, it's 100 to 1,000 times more aggressive than 6. So here's a perfect example. PSA is 4, and for some labs it would say, oh, your PSA is only 4, you're fine, you shouldn't worry about it. But you should if you're HIV positive. I don't know if you are or not, but if you're HIV...
I wasn't then.
If you're HIV positive, you could have a more aggressive cancer at a lower PSA. All right? So you be aware of that, even if you're primary care doctors. And we're lecturing now to our family medicine residents and our internal medicine residents to try to teach them about all these things to help them understand. And so really good example, you could have very easily been said, oh, your PSA is only 4, we'll see you next year. And then next year, PSA is 7. And you do a biopsy and like, oh, we're really sorry, but you have Gleason's 9 or 10 cancer. And then he had a prostatectomy at City of Hope, and it had already grown outside of the prostate because Gleason's 8 is really aggressive. It's rare to see Gleason's 8 cancer, 8 out of 10, that's not already outside the prostate. And then he ended up having to get radiation.
Now with a suprapubic catheter.
Ah, so you got scar tissue. So you got a stricture from the radiation. Yeah, I'm sorry. Okay, so.
One other question.
Yes.
Before we move on. What's the effect of testosterone replacement?
Testosterone replacement is a big deal. Some of the people in the valley are just recreational testosterone users, right? They found somebody who will be like, your testosterone is normal, but man, I want to see you bulk up. And so I'm going to just give you testosterone, growth hormone, et cetera, and it will raise your PSA. And prostate cancer is fed by testosterone. It is not like gas on a fire. Okay, it's not like that, but we take testosterone away from men who have metastatic prostate cancer because the prostate cancer slows way down. Some of the cells actually die. It's not a treatment, but it will slow prostate cancer down. So make sure you tell your urologist, primary care doctor that you're on testosterone replacement. So I just biopsied a guy, young guy, 62-year-old, fairly prominent in the community here, and he was back in to get his biopsy results today, and then he confessed to me that his testosterone is like 1,500. Right, you should be 300 because he's taking a lot of testosterone. All right, so then we talked about maybe we could ratchet that down to maybe 600. And because that's probably why his PSA was so high, and his biopsy was so high. So a high testosterone will also encourage your prostate to grow, and that will cause worsening lower urinary tract symptoms. So let's talk about that. So there's a higher prevalence of LUTS in HIV-positive men, and there's multiple studies. I just printed this one from 2017 because it was fairly new. Support that. And the thing that's tricky about this is patients, HIV-positive patients will come in and their symptoms, we give a symptom score sheet. So there's 7 questions. The worst is 5, the best is 0. So the highest score is 35, the best score is 0. And they come in and we have our MAs give you the questionnaire, and then we come in to see you and you're like, wow, your symptom score is like 28 out of 35, which is pretty severe. If it's higher than 12, you're complaining to friends, family, neighbors, and your urologist. If it's higher than 12, that's typically where it gets bad. And so they'll come in with a symptom score that's much higher than that. And when you look at the prostate, examine the prostate, it's tiny. So there's something else going on in HIV-positive patients that makes these symptoms worse. And we don't know if it's a virus that's affected the bladder function. We don't know what it is. So here's what happens with lower urinary tract symptoms. As you age, the prostate gets a little bigger. So as you get older, everything shrinks except your prostate. Everything. And some people tell me their ears, but I don't know about that. So the prostate's going to get a little bit bigger every single year. And what happens is, as that prostate gets bigger, the opening through which urine has to pass to get out gets narrower. And so it's under resistance. And so if I give your right bicep resistance, it gets bigger, right? Did you see that recently in the news? There was a guy who for like 2 years only worked out the right side of his body. Did you see that? Oh, he's freakish. He's got this huge, his muscle, his neck is on pushing his head this way. He only worked out his right side. It's really funny. Search it because it's really, I should have put it up here. So that's an example of what happens. Resistance increases muscle. There are 2 muscles in your body that you don't want large. One is your heart and one is your bladder. Because when they get large and thick, they lose their effectiveness. So what happens with a thickened bladder from an enlarged prostate is you start to get urgency. Before the bladder's thickened, when you felt like you had to go to the bathroom, you could say to the bladder, okay, I got it, got the signal, we'll go in a minute, maybe even an hour, right? You could say, I'm not going to scrub out of this case, I'll go in between cases. And as you get older, the bladder gets thicker and it stretches and it says, no, we got to go. And sometimes it says, we got to go now. And if you don't go now, you leak. And that's called urgency with urgent incontinence. When you have urgency, it's because your bladder's contracting, right? It's not like behaving. It's working independent of the rest of you. And so it's supposed to stretch, we call that compliance. It's supposed to be nice and elastic and stretch and accommodate more urine while it's sending a signal that when you get around to it, we should go empty. But the thickened bladder gets to a point and boom, it just wants to empty. So we want to try to prevent the bladder from getting to that point. So men are the worst of patients. Women will just come in with little complaints. Men, they won't come in until, they're like, I can't urinate. They're like, oh, that's interesting. How long have you had this thing on your abdomen? Oh, I haven't noticed that. I'm like, okay, well, let's just ultrasound that and see what it is. Well, it's 1.5 liters of urine that you can't get out. So maybe that thing and you not being able to urinate and getting up frequently should have brought you in maybe, 10 years ago. So lower urinary tract symptoms should not be ignored. Frequently getting up at night to urinate, it's a totally different story, but getting up at night to urinate, but mainly a weak and dribbly stream. You go to urinate, you go to the hockey game, and you're standing next to someone who looks about your age, maybe a little bit younger, and his stream is like, and you're like, drip, 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 drip. You gotta come in and see us. It's either scar tissue or enlarged prostate, and it needs to be addressed. Why do we want to address it early? Because you're gonna get bladder changes. I can trim your prostate and open that channel up, but it doesn't make your bladder go back to its normal, compliant, stretchy, beautiful self. You're stuck with this big, rigid bladder. So that's lower urinary tract infections. Now, in our HIV-positive patients, they also can get this chronic inflammation and pelvic floor dysfunction. What that means is I should have brought a skeleton, but if you have a skeleton, you can see the pelvis is hollow and empty, but there's a muscle that stretches across it, and your urethra goes there. And you can get pelvic floor dysfunction where you can get spasms, which is restricting your flow. You can get pain and discomfort with urination, and that's all part of that whole thing of lower urinary tract symptoms. Prostate cancer, this is just a picture of a prostate. That big circle with the arrow is prostate cancer, and that slide is out of order, for which I apologize. Let's talk about sexual dysfunction and hypogonadism. So erectile dysfunction is prevalent in about, yes sir?
I'm sorry, before you leave LUTS, what if your problem is not difficulty urinating, but difficulty stopping?
Same thing. So there are two things going on there. One is what's called post-void dribbling, and some people mistake that for incontinence. So post-void dribbling is you go to the bathroom and you urinate, you stretch it, you shake it, you do whatever you have to do, and you think, okay, I'm good, I'm done. You zip it up, and then you take one step, and the next thing you're like, oh my gosh, what is that? And you got a couple of drips, that's post-void dribbling. But then you have a situation where you're urinating, and the urine starts coming out, and you just can't get it to stop. And so which are you talking about? Post-void
I'm
dribbling?
talking about where I get the signal, and before I can make it to the bathroom.
That's urge incontinence. And urge incontinence happens because you've lost the compliance or elasticity of the bladder. And the only thing that treats that is medication. But we need to make sure your bladder is empty. The most common cause of frequent urination that we see is a bladder that doesn't empty. So stay with me here for a minute. Let's say your bladder holds 500 cc's and you can only get out 200. Your bladder's going to fill up a lot faster than it would if I could get you to empty completely. So men in particular have the idea that because I urinated, my bladder therefore must be empty because I just urinated. And it's rarely true. So that's why in our office, you're always going to get a bladder scan. We send you to give us a urine sample, and then we scan your bladder. And sometimes patients complain about that. And the MAs will say, look, Dr. Bischoff, he's crazy. And if I don't have this, he'll yell at me. And they'll say, oh, okay, well, then go ahead and do it. It's not true. I would never yell at them. But they use that, and they scan it, and they're like, oh, you have 350 left over. And they go, oh, that's impossible. I couldn't have 350 left over. Well, the ultrasound machine's not a liar. And 350 is more than a Coke can's worth of urine. Coke can holds 312 cc's. And so if you have 350, you have more than a Coke can. So men automatically assume that because I urinated, I am empty. And it's not true. But you don't have a gauge that tells you you're empty or not, which is why we have to scan you. So one of the reasons for incontinence is your bladder's full all the time, and every time you move, laugh, cough, or sneeze, it pushes urine out. Another reason is urgency from your bladder actually contracting, right? Your bladder's contracting, and that's causing the urgency. And you do have to go, or you will have urine come out. And we treat that with medication. So a lot of medications that work on that, and Botox works on that. And I mean, it's not beautifying, but it works, right? And you can brag that you got Botox in your bladder, but and it will help with that. So we can help with urgency. A couple more questions.
So the same thing is when you go to the bathroom and you go wash your hands. By the time you dry your hands, you have to go again.
Yes. So it's the same thing, and whenever we have that complaint, we have to, number one, make sure you're empty, right? Because one of the reasons that happens is because you didn't get anywhere near empty. You thought you were, but we can prove that you were not. And the other thing is sometimes water will trigger that contraction because the bladder's thick. Why is the bladder thick? Because the bladder's thick because the prostate caused obstruction, and that's why it gets thick, and that causes urgency. There's another question right here. Okay, same question. Can we move on?
Well, Max, what, I know a lot of us all on it. What exactly does it do by taking it? What is it supposed to accomplish?
Good question. So, do you mind telling us if you're on Flomax? How many of you are on Tamsulosin or Flomax? Oh, far less than I thought. Yeah, I thought all the hands were going to shoot up. All right, so Tamsulosin or Flomax is what's called an alpha blocker. You have smooth muscle in your prostate. And so the prostate's a reproductive organ, and with ejaculation, the prostate squeezes to push fluid out. And the muscle that squeezes the prostate like a sponge to push fluid out, that's smooth muscle. And so Flomax blocks the smooth muscle. Before Flomax, we only had Cardura or Hytrin, which are high blood pressure medications. Some of you may be on that. It helps with blood pressure, but it helps relax the prostate. But we would push the doses for Hytrin and Cardura up so they would get lightheaded, dizzy, and fall down. So then they came along, and I think it was Merck who first found it. They found a very specific prostate alpha receptors, and they created Flomax, which selectively blocks the alpha receptors in your prostate, but not your blood vessels. That's the beauty of that medication. So we have a lot of people on it, and you should be taking it at night, not during the morning, and it relaxes the smooth muscle in the prostate to open that channel so that you can get urine out easier. Now, the only problem with Flomax is it does nothing permanent for you. Your prostate will outgrow it, because remember, as you get older, everything shrinks except your prostate. So in the absence of doing something to the prostate, like trimming it out or putting it on a medication like Finasteride or Dutasteride, your prostate's going to outgrow Flomax. Is it a good starting drug? It's a great starting drug. But a better strategy is to start Flomax and Finasteride. So we start shrinking the prostate, which takes 6 to 12 months, and we immediately relax it so you can get immediate relief. And many people will say, I can't believe this. I took it last night and I'm just like a new person. I can be competitive in the summer games. Right? My flow is that good. And then we put you on Finasteride to help shrink the prostate, which is a better long-term prostate health strategy. Did that answer that question? Yes, sir.
I failed Flomax, so they put me on daily Cialis.
Oh, okay, so let's talk about daily Cialis. So the ED medication companies, they were desperate to sell more ED meds. Desperate. They were charging in those days $70, $50 for a Viagra tablet, but they wanted more. So they found on some studies that with oral ED medications, that it improved urinary symptoms. And so they got a new FDA indication, which was the low-dose daily Cialis, sildenafil, everything. And for some men, it really does help relax the prostate. And some men, though, think that they can get away with that making their erections a lot better because it's Cialis, but the erection dose is 20 milligrams. And so it's not great for erections at all. It's 5 milligrams a day. And it's just okay to help with prostate symptoms. Some men get just a really remarkable improvement. And so that's the story on those daily ED medications. Did that answer that, or? Yeah. All right, are we moving on? Yes. I gotta keep track of the time. Okay. I kind of lost track of where I was at. Oh, yeah, sexual dysfunction. So ED is present, 50 to 70% of HIV patients have erectile dysfunction. Now, erectile dysfunction is a loose term. It really means that you cannot get and maintain an erection sufficient for satisfactory intercourse. So it's kind of wide open. I mean, what does that even mean? What is satisfactory? Blah, blah, blah. It's difficult. So then we have this problem of low testosterone, which is what hypogonadism is. Hypo means low. Gonadism, or gonads, are the hormones made by your testicles. So low hormones coming from the testicle. So the problem was, can anybody see the chart well enough to read what some of the symptoms are? No? Let me see if I can. Anybody read them? Like, I've got my long distance reading class.
Fragile skin.
Okay, fragile skin. So who over 70 doesn't have fragile skin? Okay, read another one.
Reduced muscle tone.
Reduced muscle tone. Who over 70 doesn't have reduced muscle tone? Fatigue, right? Weight gain, decreased energy, decreased libido. So these are non-specific. So every day people will come in and we talk about their PSA, and on the way out they say, oh yeah, by the way, my testosterone is low, I need testosterone. And you say, okay, wait a second. Why do you have that? Well, and they mention those symptoms. So we do a lot of testosterone checking, and about 20% of men in whom we test their testosterone have actually a low testosterone. So 80% are just living the stressful, hectic, crazy lives that we live that cause all of those things. So if you're having those things, though, it's worth checking your testosterone. But if your testosterone is normal, please don't beg your primary care doctor to boost it to supernormal levels, because it really does not. It really is not the panacea that many people think it is. And it does not improve erections. So one of the big misconceptions out there is if my testosterone was higher, my erections would be like so impressive. And it's not true. So testosterone will increase your sex drive, your desire to have a good erection, but it won't give you a good erection. That's a totally separate mechanism. Yes, sir.
But when I was given testosterone before it was prostate cancer, and it was because I was given it for depression. And so the question is that a good source?
No. It's not a common cause of depression either. Not at all. So if your testosterone is low, which means well under 300. So the other day I had a young guy come in, he said, I think my testosterone's low. And I'm thinking, I didn't say it. I'm thinking, you're gonna be in that 80% that is normal. But I sent it, it was 80. 80. Right? So profoundly low, and he was a young person. Well, it turns out he's a really heavy pot smoker. And heavy marijuana use decreases the volume of your testicles. So anabolic steroids, outside, if I give you steroids, testosterone, your testicles say, hey, you don't need me, because my job is to make sperm and testosterone. And you're getting testosterone from somewhere, so you don't need me, and so they just shrink. And then if you decide, oh, I changed my mind, I don't want to be on testosterone anymore, they don't just wake up and go back to their normal testosterone factory selves. They stay small and shrink. So anabolic steroids, outside testosterone, common cause of small testicles. And chronic marijuana use, really common cause. So you'll get these younger guys and they're like, man, I don't know, my testicles seem like they're getting smaller. And I'll say, well, do you smoke much pot? And they're like, oh, not very much. I'm like, not very much compared to who? Right? Because your testicles are this big, and so you must be smoking a lot of pot. And then they'll be honest and say, you know what, I do smoke a lot of pot. And that's a really common cause of hypogonadism. Okay? But men with HIV who are not pot smokers also have hypogonadism and low testosterone, more than the general population. So if you're going to get a testosterone, you're going to get free testosterone and a total testosterone. Because your total testosterone can look okay, but your free testosterone can be too low. And it's the free testosterone that's actually the magic in your body. It's not the total testosterone. So ask for free and total. But please don't just say, yes, I hear what you're saying, Dr. Bischoff, my total testosterone is normal, my free testosterone is normal, I want testosterone. All right? Because it's not going to help you. Any questions? Yes, sir.
Yeah, you keep mentioning men with HIV. Are you saying men with HIV who are undetectable or non-detectable?
Really good question. So the question was, are you talking about HIV detectable or undetectable? And it turns out that just having HIV will lower KIT. And some people will lower their testosterone, whether it's detectable or not. And we don't know if it's because the inflammatory problems with HIV knock the testicles out, or what that is, but even when you replace it or get them on ART so that their numbers are normal, the testosterone does not always come back to normal. Did that answer that? Any other questions?
Are there alternatives to GRT?
There really aren't. So, really good question. Thank you for asking that. So I'm kind of an anti-supplement guy. And the reason is we've done a bunch of studies that have shown that some supplements are really dangerous. So there's a beautiful study that I was involved in about 15, 20 years ago, and it was, we thought selenium would decrease your chance of getting prostate cancer. And we thought vitamin E would decrease your chance of getting prostate cancer. So we participated in a study with NIH, which was $1 billion study. I mean, even today, that's a lot of money, right? And we put you on these different concentrations of selenium, vitamin E combinations, or placebo. And you had to come in once a week, and we did fingernail clippings to make sure you weren't cheating and taking drugs that you weren't supposed to be taking. And it was very detailed. It was that detailed. Fingernail clippings to see what your vitamin concentrations were. And the NIH, after just 4 years, shut the whole study down because selenium was far more likely to cause you to become a type 2 diabetic. And vitamin E was far more likely to cause you to get prostate cancer. So the NIH said, no, it's a positive study, we can stop. You can stop right now. They published it. And people still think that if you can buy it over the counter, it must not be harmful. It's just not true. It's just not true. That's the first thing I have against supplements. The second thing I have against supplements is it's unregulated. So just a political note, Jay Bischoff was hoping that when Kennedy got named Secretary of Health, that he would regulate the supplement industry, because it's totally unregulated. And he did. He did a bunch of wacky things. But the most important thing he could have done is say, if you're going to say that this liver supplement helps lower your liver enzymes and protect you from all of your bad behaviors, you have to prove it. And we hear that commercial here in the Valley all the time, and there's no proof to it whatsoever. So, all of these testosterone replacements that we hear about, it'll boost your testosterone, blah, 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 it doesn't. And we know it doesn't because we've tested it. There are some oral testosterone replacements, but you have to have a prescription. So all the supplements that you're reading about out there, the fact that you can get it without a prescription doesn't mean it won't hurt you, number one. Number two, the testosterone and erection enhancing medications have been shown in double-blinded placebo-controlled trials not to be helpful. Beta prostate, cell palmetto, all of those, we've studied those in urology against placebo, and placebo outperforms sal palmetto and beta prostate in every trial. So, I think, I kind of got on a tangent, I'm sorry, but I think that you were headed down the question, can I boost my testosterone with stuff over the counter? Is that where you were going? Yeah, and the answer is no. All right, the answer is no. Now, let me tell you about one supplement that actually is incredible, and that's Centrum Silver. Okay, and every single thing in Centrum Silver has a scientific paper that supports its health benefits to you, right? And every time a new publication comes out that says, whatever, folic acid in a higher concentration is better, Centrum changes Centrum Silver to include that. And it's the only vitamin out there that actually has science behind it. Yes?
I've been on vitamin B daily and vitamin D once a week for a long, long time. I know you're not my doctor, but is there any reason for those supplements to be part of a person living with HIV in their ongoing medical regime?
So not specifically for HIV, because that hasn't really been studied, but vitamin D and B12 can support bone health. And we don't really have any good evidence that HIV affects bone health in the way other diseases do. So we don't have that. But that's why you're on those medications.
And do they have adverse effects that you know of, those two supplements?
Those two have not shown to have any adverse effects.
Okay.
Yes, here and then here.
Is that a supplement, but what about HCG?
Oh, so HCG is interesting because it can boost your testosterone production. It can encourage the testicles to do their job. Yeah. So HCG can help.
That makes your balls not shrink.
Correct. That's right. Because it tells the testicles, hey, we should make more stuff. Testosterone, sperm, we should make more stuff. I don't know about that. Yeah, I don't know. I don't know the research on that. Yes.
There is a lot of discussion online about beetroot powder.
About what?
Beetroot powder.
Right.
Actually, it's not.
Yeah. Yeah, unstudied. So in order for it to get on the good list, you have to do a placebo-controlled double-blinded trial. So what does that mean? So many of you know, but for those who don't, you take 100 people and you say, we think that this supplement does X. And you take 100 people, 50 get the thing, and 50% gets a placebo. And the doctor doesn't know, the researcher doesn't know, and the patient doesn't know. And then you measure whatever it is you're trying to measure. So sal palmetto, for example, is supposed to help you urinate. And so we did 1,000 men in urology. It was a beautiful study. And 1,000 men were on and half of them got placebo, half of them got sal palmetto. Men didn't know, doctors didn't know, and we just measured their flow. We measured their flow rates, we measured their symptom score, and then it was a crossover trial, which is the most beautiful trial of all. Then you cross them over, and they still don't know. You're like, okay, for a year or 6 months you were on this drug, and now you're going on the next drug. And nobody knows. And the crossover trials and the double-blind placebo-controlled trials show that placebo outperforms sal palmetto in every arm. So there's a very strong psychological effect. And that's what they prey on. They say, look, Juan in San Antonio, he took this, and his erections lasted for like 90 minutes. And you say, wow, I wonder if I could be like Juan. And so you take it, you try it. But see, that's not a study, that's a testimony. Okay, should we move on?
Yes.
Okay, so HIV positive men, ED is a problem, hypogonadism is also a problem, so we should check that. Now, what about nephrolithiasis or kidney stones? It's a big problem. It's not as big a problem now, but nidinavir caused a lot of stones, and the frustrating thing about that is those stones don't show up on a plain x-ray. So uric acid stones don't show up on a plain x-ray, and the HIV medication stones don't show up on a plain x-ray. You have to do a CAT scan. So patients would come in writhing in pain, and you just get a plain x-ray, and you'd be like, I don't know what's going on with you. And they clearly they were doing the kidney stone dance, which is a really specific thing people do in the ER when you have kidney stone. And then you do a CAT scan, you see a big stone. And they're really soft, mushy stones, those stones. And so you go up there, and the laser, it was kind of hard to break them up with the laser because they're sort of soft. So we have to basket them out and break them up. So increased rate of kidney stones in HIV positive versus HIV negative, including the non-nidinavir stones. And so there are really complex metabolic changes and can also be associated with dehydration. So why would you be dehydrated? Because many men with HIV have lower urinary tract symptoms. So the more I drink, the worse my lower urinary tract symptoms are, so I'm just not going to drink very much. And then my urinary symptoms are okay at work or at play or in sports, etc. And then I get dehydrated and it perpetuates that. HIV patients have a slightly higher rate of renal dysfunction than HIV negative men, and so that can also contribute to that. Some of the antiretroviral agents we talked about cause crystals, so nidinavir would cause crystals in the urine. They're a very specific type of crystals, and they would precipitate out. Once you get a crystal precipitating out, it will catch other ions like calcium. So if I can get a crystal to start, calcium will just dogpile on it, and then I'll get a stone. So that was part of the problem there. So we need to, urologists especially, are much more aware of that here than in other places. So we're pretty in tune to that. Let's see. We talked about the protease inhibitors, we talked about radiolucent, which means you can't see it, and mixed composition. Okay, I think we covered that. Any questions about kidney stones? Anybody have any questions about that? Anybody suffered from those kidney stones? Yeah, really, really common, super common. Okay, so this is LUTS. I'm sorry, I've got my slides a bit out. We talked about that. Okay, let's finish off the time we have with HIV-related malignancies. So most of you are aware of the Kaposi sarcoma, and a lot of people think that this just shows up on the penis. A lot of doctors think this just shows up on the penis, and it's one of the more rare places that you see this sarcoma. And it develops a lot of blood vessels and these little maculopapular lesions that show up, and they can show up anywhere, orally, in the intestines, in the skin, and also in the lungs. And if your CD4 is less than 200, you're more likely to have that. So when I talked to the primary care doctors about this, they were kind of surprised, and they said, what, you can get oral Kaposi sarcoma? And you can get it on the skin, and on the back, et cetera, et cetera. So we had to show them all of that and say, yes, you can. So it's quite significant in our HIV population, and very rare HIV negative population, extremely rare. It can happen. It's typically in Africa with some really unusual inflammatory conditions, but much more common here. So the risk is about 500 to 1,000 times more likely in HIV positive patients than HIV negative patients. And the highest risk is in MSM with HIV. And for some reason, nobody knows why that is. men having sex with men. So why is it that's higher? We don't know, but it is, and it's significantly higher. And Kaposi sarcoma remains an AIDS-defined malignancy, so we have to screen for that. So when we see it in the mouth, we see it on the skin. Our primary care doctors were pretty excited to see this, and it significantly increased their awareness of this. You're probably already aware of all that, but some of our younger patients or some of our younger family medicine doctors, they're not aware of it. So we're trying to educate them about that.
Have they identified the genetic basis?
They have not. No, they have not. It's something that has to do with immune deficiency that causes those little lesions to pop up. So if you see a lesion, it should be biopsy. So this really should go to dermatology. But when I'm working with my HIV patients, I'm looking at their face, their arms, and when we examine them, I'm looking everywhere for that. And if they have it, or something that's suspicious, I just send them to dermatology and get it tested. And then, let's see, what do I want to talk about here? Oh, completely treatable, right? It is not a fatal sarcoma. When we talk about sarcomas, we tend to think about sarcomas like fatty sarcomas or muscle or bone sarcomas. Those are often fatal, but Kaposi's is rarely fatal, even in our transplant patients. Any questions about that? Okay, let's go on to non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma is a B-cell lymphoma. So you have T cells, B cells, different cells that fight immunity, and non-Hodgkin's lymphoma is B cells that are overgrowing. That's the malignancy. And it just presents as a painless nodule. So if you see somebody or in your own cell around the neck or underneath the arm, and it's just a painless nodule that's growing, don't wait. So B-cell lymphoma is one of the rare cancers that with chemotherapy we can cure it. So the truth is, if an oncologist was here and they were honest, they would agree with me, but they might argue, there aren't very many cancers that we can cure with chemotherapy. So we use a lot of chemotherapy, and testis cancer is absolutely one, curable. And B-cell lymphoma is one that's curable. So there is often outside of the abdomen, outside of lymph nodes, the CT scan, all of that orange and yellow, that's lymphoma. So we see a lot of kidney lymphoma. Patients will come in with abdominal discomfort, and people say, oh, it looks like I have a kidney stone. We do a CAT scan, and we see this kind of a picture is B-cell lymphoma. And it's more common in HIV-positive men. And why is it? It's because of this chronic immune suppression. And there are oncogenic viruses like Epstein-Barr viruses play a major role in this. EBV, Epstein-Barr virus, associated with lymphomas, much more commonly in HIV-positive men. And it seems to be less now that we have control over the CD4 counts. And so when we reverse that immune process, there seems to be less lymphoma that's happening there. Yes, question?
You probably already answered this, but if you were HIV non-detectable, does this hold true?
No. So that's a really good question. The lymphoma could have started before you became undetectable. And the lymphoma would not go away just because you're now undetectable. Did that answer that? Sure. Question over here.
It's really common in firefighters, especially wild forest fires. My nephew died of non-Hodgkin's lymphoma, and he parachuted in behind fire lines and all sorts of stuff. It's pretty well documented in many publications.
Great, thanks. Firefighters. Wildfire.
Specifically around.
Okay, let's see. Non-Hodgkin's lymphoma survival for stage 1 non-Hodgkin's, 5-year survival is about 88%. For stage 4, it's about 64%. So it's still treatable, but there are people who die of non-Hodgkin's lymphoma. Yes.
30 years. I had it 30 years.
And what were you treated with?
Chopping.
Chopping. Were you HIV positive when you got that?
Yeah.
Okay. And since then?
No.
CD4 counts are normal.
I had a little lump on it, and it wasn't, back then it was, when you got swollen glands, it was always both sides. And this didn't feel like anything, and I went to the doctor that day. It was like a Friday, and Monday I started chemo. It was like, wait, and I'm still here.
B-cell lymphoma grows really, really quickly. You can,
fast growing.
you can notice the lump today and say, I'll check it out in a week or so. And all of a sudden it's 3 times the size. It grows that fast.
By the time the biopsy had calmed down, the tumor had grown like triple this. Wow.
So really, thanks for sharing that with us. So if you have a lump or underneath your arm, on your neck, don't wait. Just go in and get it. It's like men to wait. Penile cancer, it's not higher. It's not a higher association with HIV-positive men. But over the years, I've been doing this for over 30 years, and guys will come in with this huge cauliflower thing growing on the head of their penis. And you say, how long has that been there? And they're like, I don't know, maybe a year or 2.
It's not a gay man.
So if there's something that's a little bit out of the usual, just come and get it checked. Because when the penile cancer is that aggressive, you get a penectomy. Right? You lose it. Okay, so let's talk about, we're going to quit on invasive cervical cancer. Much more aggressive in HIV-positive patients. And that's because it's associated with HPV 16 and 18, and that is an extremely aggressive virus. When I was a medical student, I was at Walter Reed, and we had 4 women on the floor who were active duty soldiers, and they had metastatic cervical cancer. And one day, a couple of them just ran into each other in the hall. They're like, hey, there's a lot of camaraderie in our military folks. They said, well, what are you here for? Where are you from? So I came in from Germany. Oh, I came in from Germany. Where were you? I was at Landstuhl. Where were you? I was at Rhein-Main. And they're like, what are you here? I said, cervical cancer. I'm like, oh man, that's what I have. And then they'd find another girl. And when they're sitting around lunch one day, they got it from the same guy. The same guy was out there, super transmitter, HPV 16 and 18. Yes?
At the beginning, you said you talked about sexual function and dysfunction. A good friend of mine and I saw Dr. Wolfson over here as a treatment. We both got finasteride and we both lost a great deal of our erection.
Oh, okay, let's go back to that. So the comment was, we both got finasteride and we both lost our erection. So if you look at the placebo trials, 4 to 5% of men on finasteride got erectile dysfunction compared to 3%. So it is slightly higher. And if you have it and you get it early and you stop it, your erection should come back. But we also have to make sure we're talking about the same thing. When patients say to me, hey, I have ED, I have to say, okay, wait a minute, stop. What does ED mean to you? Because for me, it means you cannot get and maintain an erection. But for some people, it means I took this medication and now I'm shooting blanks. I'm having erections, I'm having orgasm, and nothing's coming out. So for them, that's erectile dysfunction. And it turns out that the way finasteride shrinks your prostate to help with urination is by shutting down the factory that makes semen. Now, there is that 4 to 5% of men who take finasteride and they get soft erections. Now, let's talk about that for a second, though, because there are 19 million American men who take finasteride every day. 19 million. And more than half of those are young men to prevent hair loss. So it's the same drug as Propecia. Propecia and finasteride are the same. So finasteride is a 5 milligram tablet. That's your prostate dose. Insurance companies love to pay for that. Propecia, 1 milligram dose, and insurance companies won't pay for that. And if there were over 10 million young men taking Propecia to protect their hair who also had erectile dysfunction, they wouldn't be taking finasteride for hair. So does it cause erectile dysfunction? It absolutely can. It absolutely can. Is it common? No, it is not common. So it's worth trying it. Don't be afraid to try it. So finasteride shrinks the prostate, and that study I was talking about that was published in 2002 shows that finasteride decreases the chance you get prostate cancer by 30%. It decreases the chance we have to go in and trim the center of your prostate out so you can urinate better by 70%. And then your hair grows back. So there are 3 great things that finasteride will do for you. Now, since you brought it up, I forgot to say that if you're on finasteride, you have to double your PSA value to interpret it. So finasteride artificially lowers PSA. So if you're on Finasteride, your PSA is 3, and you're like skipping around saying, I'm incredible, look at my PSA is 3. It's not, it's 6. So when you're on Finasteride, we double the PSA. Sometimes the docs forget to do that, but you should not forget to do that. Yes?
How many years do you have to take before you see a difference? For example, I've been taking it for 9 years, and I don't know if my size is the size of a walnut or the size of a grapefruit. So I mean, I have to go and get a test.
Can I ask you how old you are?
90.
You're 90. So you started taking it when you were 80, and it's too late. So your prostate, by the time you're 80, was already gigantic. So we can shrink it a little bit. It's pretty good for shrinking. It's better for preventing it from getting bigger. So by the time you're 80, we start you on Finasteride. Your prostate's already so big, we're probably not going to be able to shrink it.
So you don't think I can take it for another 10, 15 years?
Well, I think here's the other thing. We often, patients will be on Finasteride and Flomax, and they're still miserable with their lower urinary tract symptoms. And when we put a scope in, which is a really simple, easy thing to do in the office, put a tiny telescope down through the penis, through the prostate to look at it. Oftentimes, what you find in the prostate is what we call a pedunculated median lobe. And there's a big piece of prostate tissue that's grown into the bladder, and it's on a stalk. And that will not shrink with Finasteride. So you've been taking it for 10 years, and we look in the bladder, and there's this big piece of prostate tissue. Every time you urinate, it goes whoosh, and blocks you out. And until we trim that out, you're never going to get better. But if we trim that out, you wouldn't need the Finasteride. So I hope that answered that question. It's better for preventing it from getting bigger than shrinking a big 80-year-old prostate back to a 50-year-old prostate. It's better if we either started you on that much earlier. So if you're still having symptoms, go back to your urologist and say, hey, look, I'm still miserable. We got to look inside and see what's going on. MRI can help, but MRI won't always show this pedunculated lobe. So the reason cystoscopy is such a great test is because we also get to look at your bladder, and your bladder is an amazing historian. So it's like hieroglyphics. So when we look in your bladder, if we see these big, thick ridges and cellules, we know that's been obstructed for 20, 30 years. And then we can see if there's a pedunculated median lobe. And the MRI doesn't really show us that. I hope that answered the question. Yes, sir. No, it's what's called a cystoscopy in the clinic, where we just gather information. Yes, it's called a transurethral resection of the prostate. But we have 5 different ways to do that today. We can do a urolift, where we tack the lobes back open. We can do aquablation. We can do green light laser. We can do the old TURP. We have all these different things. But you shouldn't fear that. If you're really miserable from your symptoms, just come and see us. Yeah. So because we can help you. Okay, cervical cancer, it's a big deal. And higher rates of persistent HPV infection are seen in HIV-positive patients. And it tends to be multifocal, and it comes back much quicker. And it's interesting because the lower the CD4 count, the much higher the risk of aggressive cancer is. And once that starts, you can put the CD4 down to 0, and that cancer is not going to stop. It's just going to go nuts. So once it starts, it's kind of like the B-cell lymphoma, right? Once it starts, you can manage your CD4s and get those counts to lower 0, undetectable, and it still doesn't really help. But effective ART will slow the progression, but it won't cure it. It does improve treatment response. So if we fix your CD4 count and then treat you, you're much more likely to respond to that, and lower risks of recurrence. Those are the things that have to be done for our female patients who have HIV. Much more frequent testing for 30 years. So it's not something that goes away. HIV negative, 5-year survival 70%. HIV positive, cervical cancer, 5-year survival 40%, even with normalized CD4 cancer. Anal cancer, we have to talk about that. We have a lot of anal cancer here in the desert. Also HPV related. If you're having symptoms, you know someone's having symptoms, earlier with rectal cancer is so much better. And I'm seeing late presenting rectal cancers. So patients will come in to see me for lower urinary tract symptoms or other problems, and they'll say, and I just got this pain down here. I say, well, let's check it out. Let's look for hernias. Let's check the rectum, and boom, rock hard. And so we were talking earlier about sexual activity and noticing things, thinking about things, and saying things and bringing it to people's attention. The HPV-related malignancy of the anal cancer is so aggressive and seems to be pretty resistant to chemo, radiation, and surgery. So this is something that we wish we were seeing much more earlier. So when they go to oncology, you get chemo, then you get radiation, and then you get surgery. And we try to save the rectum if we can, but we can't always do that. The 3-year survival of HIV-positive men is 42% compared to 76%. And the colostomy-free HIV is 67% and HIV-negative 88%. And that's because it's so much more aggressive in HIV-positive men, anal cancer. So we can't always save the rectum and keep them colostomy-free. Well, I have extended my time, and so I should. Thank you. Are there any questions that I missed?
I don't think you mentioned testicular cancer.
So testicular cancer and HIV positive and HIV negative men is the same incidence.
Speak briefly to how to screen for
Yeah, so screening for anal cancer is mainly with a rectal examination, but sometimes patients already know they have HPV infection. That's a patient who should be screened about every 3 to 6 months. If you have an HPV infection in the anus, you should be screened about every 3 to 6 months for that progressing to anal cancer. Same thing. Yeah, also. All right, thanks for coming out. Really appreciate it. Thank you.